Hello and welcome to your ultimate guide for the D450 OA, Community Health and Population Focused Nursing course. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your D450 OA exam with total confidence. In this video we'll cover community nursing, public health, nursing process, social determinants, professional roles. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your D450 OA exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Let us start with the 3 practice areas, one of the most heavily tested ideas in this module. Picture a zoom lens running from a single patient at one end to an entire population at the other. As you move along that lens, the unit of care expands. That one idea decodes almost any scenario. Community-based nursing sits at the narrow end. The unit of care is the individual patient, or that patient within their family. The nurse gives hands-on care for acute and chronic illness outside the hospital, in the home, a clinic or a school office. The focus stays on the patient before you. Picture these clearly. A home health nurse changes a wound dressing for an older adult after hip surgery. A hospice nurse manages pain for a dying patient at home. A school nurse gives a breathing treatment to one child during an asthma attack. Each time, the nurse cares for one named person, so this is community-based. Now the lens zooms out to community-oriented nursing and the orientation flips. The nurse stops asking what this patient needs and asks what the whole community needs. She may still give a vaccine or run a screening, but the activity exists because the community was assessed and found to need it. Individual care becomes the delivery method. Think of a nurse organizing a drive through flu event in a neighborhood with low immunization rates, or a parish nurse screening blood pressure for her congregation after several members had strokes. She meets people one at a time, yet the program protects the larger group. The unit of care is a defined, recognizable community. At the widest end, we reach population-focused nursing, where the unit of care is the entire population, often defined by a shared risk. Think of every pregnant woman in a county, or every adult with diabetes statewide. Because the patient is so large, the nurse works through data, programs, and policy rather than treating each person. The classic example is the Head Start program. Data show children born into poverty entering kindergarten far behind wealthier peers. The problem was identified at the population level, and the response was a nationwide preschool program delivered through systems. Individual children benefit, but the design and reach are population focused. Watch for statewide surveillance and policy. Here is a memory tool, the BOP lens. B is based on the individual, which is community-based. O is oriented to the community, which is community-oriented. P is population-focused. The order matches the zoom, narrow to wide, and remember, the building name never decides the answer. The unit of care does. What we just covered is exactly the material in our free practice bank. These are not basic recall questions. They test deep understanding, just like the real exam, by hiding a trigger word inside a realistic scenario and asking for the practice area. Working through them now makes these distinctions feel automatic. Now, let us define public health itself. Public health is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts of society. Notice every part. It is science and art together. It prevents disease, lengthens life, and promotes health. And it works through collective effort, not individual choice alone. The mission of public health is assuring the conditions in which people can be healthy. It does not promise to personally treat every individual. It assures the conditions that make health possible. That mission produces 3 core functions you must know. Assessment, which analyzes data. Policy development, which uses that data. And assurance, which guarantees needed services exist. The scope of public health is enormous, touching nearly every part of the human environment. It covers safe water and sewage, immunization and outbreak investigation, tobacco and nutrition policy, maternal and child health, clean air, and workplace safety. The rule is simple. If a topic affects who lives and who stays well, public health claims it. The most testable difference between medicine and public health is the unit of analysis. Medicine cares for patients one at a time. Public health cares for populations. A doctor treating one child with lead poisoning practices medicine. A team that maps every child nearby and removes the lead source practices public health. Only one targets the whole group. Here is a numerical set the exam loves. Think about what causes premature death. Lifestyle and behavior account for about 50% more than any other category. Human biology and genetics account for about 20%. The environment accounts for about another 20%. And inadequate healthcare accounts for only about 10%. Let me give you a memory aid. Picture the letters L, B, E, and H for lifestyle, biology, environment, and healthcare. The values run 50, 20, 20, 10. So if a question asks for the largest contributor to early death, the answer is lifestyle. If it asks the healthcare share, the answer is about 10%. This explains a surprising story. Around the year 1900, life expectancy in the United States was roughly 47 years. A century later, it had climbed past 77 years, a gain of about 30 years. Where did those years come from? Not mainly hospitals or surgery. They came from public health, especially clean water, sanitation, and vaccination. Here is the part most students miss. About 70% of preventable early death can be addressed through health promotion and prevention, yet national healthcare spending devotes only about 3% to prevention. That mismatch is a favorite exam theme. Prevention saves lives even when it does not save money, because longer lives use more healthcare. I know we are covering a lot, and you might wonder how to practice applying it. That is exactly why I built those free practice questions. They let you work through scenarios that combine several concepts at once, which is precisely how the real exam tests you. The link is waiting in the description. Now let us turn to the goals and process of public health nursing. The goals are 3 clean lines: promote health, prevent disease and disability for all people, and achieve the conditions in which people can stay healthy. Notice those words, for all people. Health equity is built into the goal, not added afterward. To reach those goals, public health nurses follow a 5-step process that mirrors the familiar nursing process, but applies to whole populations. First, assess the needs of a population. Second, develop a plan. Third, implement it. Fourth, evaluate the outcomes. And fifth, use those results to take further action. The key insight is that this cycle never ends. Step 1 is assessment, the foundation for everything else. The nurse gathers numbers and stories describing the health of the target population. She pulls vital statistics on births and deaths, disease surveillance, census data, behavioral surveys, and environmental reports, and she listens through community interviews. The output is a community diagnosis, a prioritized list of problems backed by evidence. Step 2 is developing the plan. Once needs are ranked, the nurse chooses interventions that fit the problem, the resources, and the culture. One famous tool is the Public Health Intervention Wheel, listing 17 interventions like surveillance, screening, outreach, and health teaching. The plan sets objectives that are specific, measurable, achievable, relevant, and time-bound, spelling SMART. Step 3 is implementation, where the plan meets the population. This might mean delivering services directly, training community health workers, launching a campaign, partnering with agencies, or pressing for policy change, often several at once. Throughout, the nurse keeps monitoring closely so small problems are caught early and the program can be adjusted before they grow. Step 4 is evaluation, where the nurse asks whether the plan worked. She looks at process measures like how many people were reached and outcome measures like whether the health indicator actually moved. Did vaccination rates rise? Did asthma emergency visits fall? This is why baseline data matters. Without a starting point, you cannot prove improvement. Step 5 uses the results to take further action, closing the loop. Evaluation never just sits in a binder. If the program worked, the team sustains it, scales it, or repeats it elsewhere. If it failed, the team studies why, redesigns, and tries again. To remember all 5 steps, use APIE plus ACT. Assess, plan, implement, evaluate, then act. Let me flag 2 traps here. If a STEM asks for the very first step in addressing a population problem, the answer is assess, not implement and not partner. Assess always comes first, and if a STEM asks what happens right after an intervention is carried out, the answer is evaluate, not the next problem. Next. If some of these steps feel challenging right now, do not worry. That is completely normal, and it is exactly why I built that practice question bank. Working through those problems helps the 5 steps move from something you memorize into something you instinctively recognize. They are free and designed specifically for this course. Next, we tackle 3 words that trip up many students because everyday speech blurs them, while the exam keeps them sharp. Those words are population, aggregate, and community. They are not interchangeable. Each has a precise technical meaning, and easy-looking questions will quietly punish you for mixing them up. Let us define each with an example. A population is the largest group under consideration. It is defined by one or more shared characteristics, usually a geographic boundary like a county or state, or a shared status like all newborns or all adults over 65. The word implies a denominator, the bottom of a fraction in a rate. The nurse rarely meets every member. An aggregate is a subgroup inside a population that shares a common characteristic, especially one affecting health risk. Aggregates are the real working unit of public health nursing because a nurse rarely intervenes on a whole population at once. Think of pregnant adolescents in a county or older adults with a falls history. They simply share a risk. A community is different again. It is a group sharing more than risk. Communities share geography, identity, culture, or institutions, and members usually recognize one another as belonging together. A neighborhood organized around a community center is a community. So is a faith congregation or a high school with its students, teachers, and families. Here is a quick way to keep them straight. The word pack. Population is the pool, the largest group. Aggregate is a slice of that pool, defined by shared risk. And community is the connected group whose members know they belong. So a faith congregation is a community, while all county residents with diabetes is an aggregate. 2 related terms appear nearby. A vulnerable population is a group whose social, economic, or health status puts them at higher risk of poor outcomes and of being underserved, like people experiencing homelessness or migrant farm workers. A population at risk is a group exposed to a specific factor that raises disease chance, like adults who smoke. The most important habit is reading for the technical meaning, not the casual one. The exam deliberately uses these words loosely inside a scenario, hoping you answer from everyday speech. A geographic neighborhood is a community. All adults over 65 in the nation form a population, even if we casually call them a community. Apply the precise definition. Remember that mastering these concepts takes practice, not just listening once. The free practice questions help you turn what you're learning into exam-ready skills. They give you scenario after scenario, so telling a population from an aggregate, from a community, becomes second nature. Grab them from the link whenever you feel ready. Now, let us talk about the forces that shape who gets sick and who stays well, the social determinants of health. Health does not happen mainly in the doctor office. It happens where people are born, grow, live, work, and age. Those conditions explain why life expectancy can differ by 20 years between two nearby zip codes. The Healthy People Framework groups these determinants into 5 domains, and you should name all 5. First, economic stability. Second, education access and quality. Third, healthcare access and quality. Fourth, neighborhood and built environment. And fifth, social and community context. Almost any determinant from income to housing to discrimination fits one of those domains. Let us walk through the determinants. Income is one of the strongest predictors of health because it buys safer housing, better food, and time to seek care. Education shapes literacy, employment, and the ability to navigate the health system. A patient who cannot afford a copay or cannot read a medication label shows you a determinant at work. Employment and working conditions provide income, insurance, purpose, and either safety or exposure to harm. Social support is just as powerful. Strong relationships protect health so well that isolation carries a mortality risk comparable to smoking. Picture an older adult who stops eating well after losing a spouse. A missing social support is driving the outcome. Housing and transportation are 2 of the most consequential determinants. Poor housing exposes families to mold, pests, and lead, while unstable housing adds enormous stress. Transportation is the bridge between people and services. A patient who keeps missing appointments because the bus stops 2 miles short is not unmotivated. He faces a transportation barrier. The physical environment surrounds us with air, water, and chemical exposures that protect or harm, and children are especially vulnerable. Healthcare access depends on insurance, distance, provider supply, hours, language, and trust. Remember that healthcare access drives only about 10% of premature death overall, yet it can decide specific conditions and the disparities between groups. The exam may test 3 related words. An inequality is any measurable difference between groups, and some are not unjust. An inequity is a difference that is unfair, avoidable, and systematically produced, like higher infant death rates for one racial group. A disparity is the policy term for differences across groups. Disparities are very often true inequities. Here is a trap to watch. A STEM may describe a clinical problem and then blame patient choice. That framing usually hides an upstream determinant doing the real work. When a child has repeated asthma attacks and the apartment is full of mold, the answer points to housing, not motivation. Always look upstream before blaming the individual. As we reach our final topic, remember that understanding these ideas is only the first step. Real mastery comes from applying them under pressure, which is where those free practice questions shine. They are completely free. The link is in the description, and they were built specifically to get you ready. Now let us finish strong. The last major topic is the 16 roles of community and public health nurses. The exam describes an activity and asks you to name the role. The 16 are advocate, case manager, case finder, clinician, collaborator, consultant, counselor, educator, epidemiologist, health planner, leader, manager, outreach worker, researcher, referral resource, and social marketer. We will group them so they stick. Start with 2 roles students confuse: advocate and case manager. An advocate speaks or acts on behalf of clients to secure rights, services, or policy, like a nurse testifying before the school board for an asthma policy. A case manager instead coordinates a full set of services for one client over time, arranging therapy, equipment, and follow-up. Next, separate the case finder from the outreach worker. A case finder actively searches for cases of disease not yet known, like testing shelter residents for tuberculosis after a cluster. An outreach worker is broader. She goes where a hard-to-reach group lives simply to make first contact and build trust before any testing begins. The clinician and collaborator are easier to spot. A clinician gives direct hands-on care such as vaccines, screenings, or a dressing change, and public health nurses do this routinely. A collaborator works as a true co-owner alongside other agencies toward a shared goal, like a nurse partnering with the hospital, schools, and housing authority. Now, compare the consultant and the counselor. A consultant gives expert advice from the outside without owning the project, like reviewing a school district lice policy and recommending changes. A counselor works one-on-one to help a client explore options, decisions, and feelings, often using motivational interviewing. The counselor explores readiness and emotion, not facts. This brings us to the educator versus the social marketer, a favorite exam trap. An educator delivers content directly, teaching a class on infant-safe sleep or leading a diabetes workshop. A social marketer instead builds a structured campaign to shift behavior across a population using audience targeting, branded messaging, and media channels. 2 data-focused roles round things out. An epidemiologist studies the distribution and determinants of disease in populations, investigating an outbreak, calculating an attack rate, and identifying the source. A researcher generates new, broadly applicable knowledge through systematic study, like a formal trial comparing 2 home visiting models. Research aims at knowledge that generalizes widely. The leadership and program roles are the health planner, manager, and leader. A health planner designs future programs from assessment data, like a multi-year plan for prenatal care across several counties. A manager runs daily operations, supervising staff and overseeing budgets. A leader sets vision and mobilizes others. Planner designs, manager runs, and leader inspires. The final role is the referral resource, which connects a client to a service and follows up to confirm the linkage happened. Think of a nurse who links a food-insecure family to a food shelf and checks back the next week. The trick is to read the scenario for the main verb, then match it to one role. Let us pull everything together. The 3 practice areas form a zoom lens from community-based care of individuals to community-oriented care of a defined community to population-focused care of an entire population. And public health is population-focused, working through organized effort to assure the conditions in which people can be healthy. We learned that lifestyle drives about half of premature death, that most of the last century gain in life expectancy came from public health rather than medicine, and that the nursing process moves through assess, plan, implement, evaluate, and act in a cycle that never closes. And we sorted population, aggregate, community, and the 5 domains. Do not forget to grab those free practice questions from the link in the description. With the depth you have gained today, plus steady practice, you will walk into your exam genuinely prepared. Test the 16 roles against scenarios. Drill the population concepts and quiz yourself on the percentages until they feel automatic. You now hold the full foundation for community and public health nursing. Read each scenario slowly, find the unit of care, name the goal, and the right answer usually reveals itself. Trust the precision you built today. Keep practicing with those free questions and walk into that exam room with confidence. You are ready. Good luck.